Hi, this is Professor Blades, and we're going to do a basic arrhythmia video. I used to teach basic arrhythmia, and this is a similar presentation that we used to do at the hospital. So with basic arrhythmia, first of all, you have the anatomy of the heart. So the heart is a four-chambered structure made up of two receiving chambers called the atria and the two pumping chambers called the ventricles. The right atrium receives oxygen depleted blood returning from the body through the superior and inferior vena cava. And so that's right here and right here, right? And the right ventricle pushes the oxygen poor blood to the lungs through the pulmonary arteries. The blood is oxygenated in the lungs, and oxygen-rich blood is returned from the lungs through the pulmonary vein into the left atrium. The left ventricle pushes the oxygen-rich blood out through the aorta, which directs the blood to all of the other parts of the body. The left ventricle is a high-pressure chamber that is approximately 3 times thicker than the right. And the right and left atria and ventricle chambers are separated by a septal wall or septum. And they all have different names to them, as you can see, the mitral valve, tricuspid valve. Okay. And this is the cardiac cycle. So in the first one, this is passive ventricular filling, and AV valves allow blood to pass into the ventricles. So then we have the second one, which is atrial contraction, also known as the atrial kick. And then you have the ventricular stroke. We're going to watch a video. Okay.
The heart is a muscle about the size of your fist. It lies behind and to the left of your breastbone or sternum. The purpose of the heart is to pump blood through blood vessels, arteries, and veins to all parts of your body. The inside of the heart is divided into 4 chambers. The top 2 chambers are called the atria and are collection chambers for blood. The bottom 2 chambers are called the ventricles and receive the blood from the atria and pump it to the lungs and the body. The chambers are separated by valves, which control the direction of blood flow. There are 4 valves: tricuspid, pulmonic, mitral, and aortic. Circulation begins at the right side of the heart, where blood from the body comes to the right atrium. This blood passes to the right ventricle, where it is pumped to the lungs to receive oxygen. Once it receives oxygen, it flows to the left atrium and then to the left ventricle, where it is pumped to the aorta and the rest of the body. On the right side of the heart, the tricuspid valve separates the right atrium and the right ventricle, allowing blood to enter the ventricle but not flow backwards to the atrium. Blood flows through the pulmonic valve to go to the lungs. On the left side of the heart, the mitral valve separates the left atrium and the left ventricle. Blood flows from the left ventricle to the aorta through the aortic valve and to the rest of the body. Arteries carry blood with oxygen and other nutrients throughout the body. Veins take blood back to the heart, which pumps it to the lungs to be oxygenated. The heart arteries, coronary arteries, provide oxygen and nutrients to the heart muscle. The right coronary artery supplies blood to the bottom and the back of the heart. The left coronary artery splits into 2 vessels. One branch supplies blood to the front of the heart. The other branch delivers blood to the left side of the heart. An electric system transmits signals throughout the heart to control its pumping. The electrical signal starts in the sinoatrial or SA node, which is located in the upper portion of the right atrium and is known as the natural pacemaker of the heart. The electrical signal passes down to the lower chambers of the heart via the atrioventricular or AV node, which controls the signals so the atria contract before the ventricles. In the ventricles, pathways carry the signal throughout the muscle so that they contract at the same time to pump blood to the lungs and through the body.
Okay, so the importance of a normal rhythm. The atria contract before the ventricles. This provides 20 to 30% more volume into the ventricles before the ventricle contract. The loss of atrial kick can significantly reduce the stroke volume. Stroke volume is best when ventricular rate is in a normal range, and the ventricular rate is the most important determinant of a patient's ability to tolerate abnormal rhythms. So one of the things that I always try to explain is, people can be an AFib and be symptomatic, and they can be an AFib, and we'll learn what AFib is throughout this chapter. But AFib is when there's, not there's a quivering of the atria, so they don't completely empty, and it also for the patient can make them oxygen deprived, short of breath when they walk. That's if they're symptomatic. There are people who stay in AFib and their heart has gotten so used to being that way and their body that they do not have to. They're still on medication because the one thing AFib can cause is blood clots and therefore a stroke or a heart attack. But they still can. They function fine. Some of them function fine staying in AFib. Others can go in and out of AFib in a regular rhythm and they know it right away. So that's the important part. And so the functions of the heart, there's two types of cells. You have the electrical, and there are electrical conductive cells which initiate electrical activity and conduct it through the heart. There's an automaticity, a property of cardiac electrical cells that allow them to discharge an electrical current without an external stimulus. So it's like an automatic thing. Your heart beats no matter what. You don't have to think about making your heart beat, right? So then you have the mechanical cells. These are the contracting cells, and they respond to the electrical stimulus and contract to pump the blood. And the heart will respond with contracting only if a stimulated by electrical activity. You cannot have mechanical response if there's no electrical response. So that's, for example, that's why they use the paddles and shock someone, because they need an electrical current in their heart, sometimes to stop it and make it restart in a better rhythm, and sometimes just to make it start. So you have the sodium pump. So you have polarization and the cells at rest. So if you notice, the potassium's in the cell and the sodium's outside. So with depolarization, the cell will contract and they switch places. And then with repolarization, they return to baseline. So then they switch again and they go back to the potassium inside and the sodium outside. So, chemical basis of impulse formation. So, polarization is the ready state. Electrical charges are ready, they're balanced, they're ready to discharge. With depolarization, this is the discharge state. So, they have a discharge of energy that accompanies the transfer of electrical charges to the cell membrane. And then with repolarization, it's recovering, return of electrical charges to their original position. Okay. And there we go. So this is a typical EKG, and this is also the rhythm you see on all the movies, that they're accurate, or that they're alive. And when they die on the movies, it just goes to a straight line, and that's not how it happens anywhere. So you have the atrial depolarization, and that's this period in here, and this is called the PR interval. And then you have the QRS duration, which is also the ventricular depolarization. And then you have the QT interval down here. All three of these intervals can be important with different things. And then you have the ventricular repolarization. And we have it the PQRS and T. I've never seen a U. They always talk about the U in a lot of things, but most people that I know, you can't really see in that rhythm. Okay. So this is the 6 parts of the electrical conduction system of the heart. So the SA node right here, this is the SA node is the um, natural pacemaker of the heart. Sorry, lost my train of thought there for a minute. And so there are 6 parts of the electrical conduction system, as you can see, and they play an essential part of the rhythm interpretation. And they kind of need to be memorized. This system will help you understand normal and abnormal rhythms and where that abnormal is. In a normal heart, the first impulse starts at that SA node. It fires, and the impulse travels through the atria by way of the intra-atrial pathways and the AV node by means of the internodal pathways. And the AV node has this conductive tissue, but it does not have any pacemaker cells. The pacemaker cells are actually located between the atria and the bundle of His in an area called the AV junction. And the bundle of His conducts the electrical impulse down to the right and left bundle branches, and these branches are located in the right and left ventricles. So if you think about that other picture of the heart, um, you can see it. Sorry, I hit the thing. You can see it on this, like that heart picture over top of this. Okay. All right. So here we're going to look at the cardiac conduction.
Let's take a closer look inside the heart. The yellow objects you see on the left are not nerves. They're actually specialized cardiac muscle cells in the walls of the heart. Their job is to send signals to the rest of the heart muscle and cause a contraction. Together, this group of cells is called the cardiac conduction system. The main components of the cardiac conduction system are the SA node, AV node, bundle of His, bundle branches, and Purkinje fibers. Let's follow a signal through the contraction process. The SA node starts the sequence by causing the atrial muscles to contract. That's why doctors sometimes call it the anatomical pacemaker. From there, the signal travels to the AV node, through the bundle of His, down the bundle branches, and through the Purkinje fibers, causing the ventricles to contract. This signal creates an electrical current that can be seen on a graph called an electrocardiogram, or EKG. Doctors use an EKG as a way of seeing how well the cardiac conduction system works. Any changes to the EKG can mean serious problems.
Okay. So these are the pacemaker sites. So you already know that the SA node, oops. So you already know that the SA node is the natural pacemaker of the heart. And then also the AV junction, as well as the ventricular, the ventricles can actually initiate a cardiac electrical impulse. The difference is when the SA node is working and the heart rate it's a regular rhythm, is usually between 60 and 100. An AV junction rate is less than that, which is usually less than 60. And then ventricular is going to be like 20 or 30. So obviously you cannot maintain the heart with that type of rhythm because it's not beating fast enough to pump the blood through the body. All right, so you have inherent rate changes. So here the SA node, like I said, the beats are 100, 60 to 100 with the SA node, and then they go to 40 to 60 with an AV junction, and then 20 to 40 with ventricular. And so there's a lot of things that can influence the rate, irritability. If a site becomes irritable and begins to discharge impulses at a faster than normal rate, it can even override the SA node and take over. And then you have escape. This is when the SA node drops below its inherent rate or may fail altogether. If so, the site with the next highest inherent rate will take over the pacemaking role. And so that's usually the AV junction. Okay. And we're going to talk about skin prep for electrodes in another presentation. But this is where a 5-lead EKG goes. Okay, you have the right upper, left upper. You have the one on the chest, and you have right lower and left lower. Now these are colored. They're green and black and red and white and brown. And then this is where a 3-lead would go if you just have 3 leads. And so with when you put on the leads, that's what, when you actually apply them, you're looking at what you want to be able to read. And so the basic rules of an EKG is if the electricity flows toward the positive electrodes, the pattern produced on the graph paper will be upright and deflective. If the electricity flows away from the positive electrode or towards the negative electrode, the pattern produced on the graph paper will be downward deflection. So this is what it's talking about. You can actually have that beautiful little regular sinus rhythm that we saw earlier, but in that case, the peak is going upside down. And sometimes it's just how they put the leads on. So this is monitoring here. As you can see, it's going the right direction. And so therefore it's this nice, beautiful little rhythm. And so these are the waves of the cardiac cycle. So the P wave is depolarization. So that's here. The Q is the first negative wave preceding an R wave, and the R wave is the first positive wave. And then you have your second negative wave, which is the S wave. And then you have this T wave, which represents ventricular repolarization. And the one thing that we always look at when we're reading cardio echo or EKGs is you want that P wave to be just beautiful and upright and matching, and that's how you can tell the difference in certain rhythms. Low voltage waves follow the T wave, usually are not apparent and not always present, and that's that U wave I was talking about before. You don't always see it. And this is just different ways that the R wave can be seen on graph paper. And then this is important to know. So, you know, this is a cardiac graph thing here, right? And so you see these little boxes. And so if you look at this, this is the little box right here, if it was just in red. So one little box is 0.04 seconds, 2 boxes is 0.08 seconds, 0.12 seconds, and 0.16 seconds, and then 0.2 seconds. And so this is that on this grid. So that gives you an idea of how long it takes for a heartbeat. So not very long, right? I mean, this is like the beginning of the heartbeat, the end of the heartbeat. And if this is 0.2 seconds between here and here, so it's 1, 2, 3. So 0.6 seconds, in 0.6 seconds, you have a heartbeat. And so the measurements of the cardiac cycle, so when I was talking about it before, we usually look at the PR interval, which is actually PRI. It's the beginning of the P wave, and it goes up to the first wave of the QRS, and that's that atrial depolarization. You have QRS interval. It's the beginning of the first wave of the QRS until the last wave of the QRS, and that's ventricular depolarization. And then you have that ST segment, and that's the time from the end of the last wave of the QRS complex until the beginning of that T wave. So here it is, kind of pictured out with color. And so these are the numbers that you really should remember. You need to know that it's a 0.04 second small square, and that the PR upper normal for a PRI interval is 0.20 milliseconds. And then upper normal limit for QRS is 0.12 milliseconds. You'll hear someone say a lot of times that they have an extended QRS. Medications can do that. Different things can do that. So the refractory period, it's absolute with no impulse could cause depolarization, and relative with some of the charges are back to their polarized state. So a strong impulse could cause a premature abnormal discharge. And so a lot of times you may hear that called a PVC or a PAC. There's different names for those. Okay. And then you have artifact. If you are ever on the floor and you go look at someone's EKG or their ECG and their leads, they'll probably tell you to go check them, because right here, this is like if a patient moves, if they brush their teeth, it can look exactly like someone going into VTAC. So that's why we always say you treat the patient, not the monitor. You have to go check and see what your patient's doing and what's going on with them. That's very important. And so you have the R to R interval. This is how you can tell if it's regular. So this is the PQR, right? So we're measuring from here to here to here to here. And that's when you use those little calipers that you'll see people on the cardiac floor having. I always say they look like how we used to draw a straight circle, but or a regular circle, not a straight circle. But so if this is even, if it is the same from here to here, then that rate's considered normal. Whenever you have uneven, as you can see, these are not evenly distributed, then that's an irregular rhythm. So you can have a regular rhythm, a basically regular, which means um, it has a few deviations. You can have totally irregular, which obviously this one is, and you can have regular irregular. So if you look at this one on the bottom, it's not even all the way across, right? The R to R. But if you look at the pattern is still the same. So that would be called a regular irregular. And calculating heart rates, you can do them different ways. The best way to calculate somebody's heart rate is to count a 6-second strip and multiply it by 10. So you literally just go R to R's, but you have to be after this slot and before this slot. So this one actually started before, so that's why they started here with this R. So 1, 2, 3, 4, 5, 6, 7, 8. So this is like about 80. This person's uh, heart rate, pulse rate is going to be around 80 is what it's saying. These are other ways that you can calculate it. You don't need to worry about that. The one thing that we always look at in order to make sure that something is a regular rhythm though, the first thing you always look at are those little P waves. So this has a P wave, this has a P wave, that's a P wave, that's a P wave. And if you look, do those P waves look exactly alike? Yeah, they really do. So that's a good thing. And then you have the PR interval, are they constant? Do you constantly have a PR interval, and is it in that 0.20 seconds that we talked about earlier? And then you have that QRS complex. Are all the QRS complexes of equal duration? What do they measure? Do they look the same? Are they same distance apart? That kind of thing. So the 6 basic steps for rhythm interpretation is you look at the rate, you look at the regularity, you look at the P wave to make sure it all looks pretty and it looks the same all the way across. You look at your P to R interval, your QRS width, and then you can just determine the rhythm interpretation. So I don't want you to feel like this. So let's just kind of go back through the basics. You do have to study things like this, and If you do work a cardiac floor, it becomes like second nature, but it's one of those things you kind of have to you do all the time in order to remember. So rhythms from the sinus node are considered normal sinus rhythm, sinus Brady, sinus tach, or sinus arrhythmia. And the reason being is this SA node fired and made the heart start through its depolarization and polarization or its pumping. Okay. And so for normal sinus rhythm, this is what you're looking for. Is it regular? So are those R to R's even? Is the rate between 60 and 100? You count your R to R's in that 6-second strip, and was it between 60 and 100? You look at the P wave. Is it uniform shape? And is there a P for every QRS? And then that PRI interval, this is when how long the PRI is, and also the QRS, is it less than 0.12? So that 0.12 is the bottom PRI, the 0.20 is the top PRI number, but with QRS, it has to be less than 0.12 seconds. And so this is a normal sinus rhythm. You can pretty much look at this and tell it is. The one way you always make sure, though, is you always measure from here to here and make sure that it's the same distance. Bradycardia is the same thing, except for it's less than 60 beats per minute. Now you say, well, you said that other one, when we were talking about ventricular rates, that it could have a rate of 40 to 60, but the difference is it's an AV junction is not going to have a P. So that's how you can tell the difference, because it did not start at the SA node where sinus Brady did. That's why it's called sinus bradycardia. And so everything else is the same. So if you look at this one, you can tell 1, 2, 3, 4. Let's say this is a 6-second strip. So this patient in particular has a heart rate of 40. And then this is another sinus Brady. Once again, if you take all those things into consideration and you measure it, you're going to measure it after this one and before that one. So 1, 2, 3, 4. It's 40. He's probably more like 48 if you really took his pulse, because it's almost 50, but not quite. And then you have sinus tach. Same thing again. You're looking for that P wave, that regular R to R, but the beats per minute's over 100. That's when we say someone is sinus tachycardia. Now, unless they are on an EKG or an ECG where you can see their heart rhythm, we would say somebody's tachycardic, right? If their blood pressure or if their heart rate's over 100, we just know they're tachycardic. We don't know what the rhythm looks like unless they're hooked up to a monitor. And then this is sinus tach. So if this is a 6-second strip, as you can see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. They're at 120. It's very regular. And if you do all the measurements, which we can learn if you want, which you'll need to know, but we'll do that in SimLab. As you can see, it does look the same. If you did all the measurements, it would just be sinus tach, which just means the heart rate's over 100. These are some more sinus tach. As you can see, when they start getting faster, though, it gets a little more difficult to look for that P wave, right? Because the heart rate is beating so fast. So if we look at these, this is actually normal sinus rhythm. Remember when I said that it can be inverted because of the way you put the electrodes on, or it's reading negative electrodes, so that's why it's upside down. But it's still normal sinus. This is still bradycardic, and this is tachy. This is sinus tach. So sinus rhythm, sinus Brady, and sinus tach on the bottom. So here's the rules if you have a sinus arrhythmia. So the regularity is just irregular. That's what makes it a sinus arrhythmia instead of sinus Brady. So if you look at the one on the top, they look the same except for here, right? It's a little bit more widespread. And then the same thing down here. So they have a sinus arrhythmia going on, something going on with their heart rate. Medications can do that. Antidepressants can cause PVCs and other heart irregularities, and so can a lot of other medication. So when they say it can cause a heart rhythm problem. This is where you can tell what it looks like. And we're not going to talk about sinus arrest versus sinus block really, but what happens is there's a pause. As you can see with sinus block, there's a pause. Everything else is still the same, but for each QRS, but then there's a dropped P to P interval in there. So if you look, here's the P, QRS, and then the P just didn't come, it didn't fire where it was supposed to. And then sinus arrest, before each QRS is identical. Now the rhythm begins after a pause. The P to P interval is disturbed. So as you can see, the sinus arrest does not mean call the doctor and tell them that your patient's in sinus arrest. That's okay. That's not a heart arrest or a heart attack or any kind of arrest with the heart. It's usually just a pause. But if a pause is long enough, then it will warrant, if a patient is not on the cardiac floor, for them to go to a regular cardiac floor. And so all arrhythmias straighten themselves out in the end. So as you can see, this was not a good heart rate. And then that was the end. Thank you so much.